So welcome to the first Department of Pediatric Grand Rounds for the new year. Happy New Year to everyone here and online. We have a real treat for you here today. We have Dr. Amanda McCoy, who is a pediatric orthopedic surgeon here at Children's in her hometown. And Dr. McCoy completed her undergraduate degree at Harvard in chemistry and physics and her medical degree at Duke. She earned an MPH at University of North Carolina, Gilling School of Global Public Health. She returned to Harvard to complete her residency in the Combined Orthopedics Residency Program, followed by fellowship at Baylor College of Medicine. After fellowship, Dr. McCoy moved to Kenya, where she served as the interim program director for the Temwek Mission Hospital Orthopedics Residency Program for 3 years, where she cared for a variety of conditions and patients with a special focus on local workforce capacity through training. Upon, lucky for us, she returned to Pittsburgh. She completed a limb lengthening reconstructive practice traveling fellowship and has developed this program here locally for our community. She serves as a Pitt Medical Clinical Skills Preceptor in our Three Rivers curriculum and serves on the UPMC Orthopedics Residency Program Education and Clinical Competency Committees. Nationally, she serves as the current chair of the Pediatric Orthopedic Society of North America's Global Outreach Committee and is on their Trauma and Prevention Committee. We are so grateful to have this global expert and local colleague speak with us today. She will be joined by Dr. Glenn Rapsinski, who is also homegrown from New Kensington, who is assistant professor here in the Department of Pediatrics in the Division of Infectious Diseases. He received his Bachelor of Science in Biology from St. Vincent College and his MD PhD in Microbiology and Immunology from the Lewis Katz School of Medicine at Temple. Dr. Rapsinski completed his residency in pediatrics and fellowship here at Children's and was part of our Pediatric Scientist Development Program. He's a CAPE-funded physician scientist studying ventilator-associated infection and diagnostic stewardship. We are thrilled to learn from our very own Dr. R. I'm going to point that out as the kids at Arsenal called him, since his last name is kind of hard to say. He was very helpful to us when we started our CHAMP program and taught the kids at Arsenal during the pandemic about COVID. So what do you get when two local kids become experts in pediatric orthopedics and infectious diseases? We have an outstanding grand rounds on what can happen when these two worlds collide. So with no further ado, Dr. Amanda McCoy and Dr. Glenn Rapsinski.
Good morning and Happy New Year. I'm very humbled to be here, and so thank you for inviting me. So today we're going to go over both the surgeon and the infectious disease perspective of taking care of acute hematogenous osteomyelitis. So first we'll start with the epidemiology, then we'll review the pathophysiology. I'll discuss the surgical approach for managing acute hematogenous osteomyelitis, and then I'll hand it over to Dr. Rapsinski to talk about the medical management, and then we'll talk about some of the long-term consequences. So first we'll start with the case. ER is a 9-year-old boy who presents with 6 days of right ankle pain and a fever to 101.6 at home. Otherwise, his medical history is pretty unremarkable, but he does have a rash to penicillin. He's in the 3rd grade and lives at home with his parents and 2 cats. So upon initial presentation, the patient had a Tmax of 37.3. Otherwise, he was non-toxic appearing. On focal examination of his right lower extremity, he had generalized swelling over his distal tibia. He was tendered palpation, and he was neurovascularly intact distally. In terms of laboratory workup, he had a white count of 9.3, ESR of 35, CRP of 6.98, and negative Lyme titers. So these are his presenting x-rays. As you can see, I do not see any radiographic abnormality. His growth plates are open. I don't see any interosseous collection. That would be indicative of infection. However, we were still concerned, so we obtained an MRI. And here on the axial view, T2, you can see that there is a collection in the intramedullary canal. If you look at the sagittal T2, it's still here. You can see it right in this area. And if we look at the coronal T2, you can see a little collection there. So based on the patient's presentation, his MRI findings, and his laboratory markers, we were concerned about acute hematogenous osteomyelitis. So let's talk a little bit about the epidemiology of osteomyelitis. So in developed countries, incidence can be anywhere from 1 to 12 cases per 100,000 children per year. And research demonstrates that there are higher incidence rates in children coming from underprivileged backgrounds. That's both in New Zealand in case of the Maori population, but also here. When you look at in the United States, children who have acute hematogenous osteomyelitis that come from underrepresented backgrounds tend to present later and require more surgery. When you look at low and middle income countries, it's much higher, almost 200 cases per 100,000 children. And we look at children who also have HIV infection in South Africa, 20% of the children were HIV positive. So in terms of location, osteomyelitis tends to occur in the tibia and the femur, and that accounts for 60% of the cases. So why does osteomyelitis happen? So as you guys are well aware, sometimes children are relatively immunocompromised and compared to adults. And so they can be transiently bacteremic. When they're transiently bacteremic, there are small sinusoids that gather near the growth plates, and that's a place of blood stasis. And so basically the bacteria pop out the small sinusoids and they kind of settle into the metaphysis. And once it's into the metaphysis, it can actually break through the cortex, forming a cloaca, and that can lead to subperiosteal abscess. Okay, if that abscess is not drained, what happens is that abscess strangulates the bone, and that leads to development of a sequestrum, but also the body's still trying to wall off the infection, and that leads to development of an involucrum. Whenever you have osteomyelitis and an intracapsular metaphysis, then there is a risk of adjacent septic arthritis. That is very common in the hip, in the elbow, in the shoulder, and in the ankle. So what are the causative organisms for osteomyelitis? So like any other disseminated infections based on age group. So in neonates, very young children, you can have Staph aureus and strep A and B. You can also have gram-negative bacteria. In children less than 2 years of age, you can have Kingella kingi in addition to Staph aureus, as well as influenza B, which is not as common with immunizations. In children 2 to 5 years of age, Staph aureus is the most common, but you can also have Kingella kingi, pneumonia, meningitis, as well as non-typable influenza or non-typical Haemophilus. And other organisms included are Salmonella in children who have sickle cell, as well as Neisseria gonorrhea in children who are sexually active. So in terms of clinical presentation, typically there's pain and point tenderness. A third of children will report a remote history of myelotrauma. And so initially in my practice, I thought it was a red herring. But what I realized now is whenever you have a small trauma, you have a hyperemic area. And that hyperemic area draws the bacteria to the bone, and then you can have onset of osteomyelitis. Often children, if they're affected in the lower extremity, will have an inability to bear weight, and they can have fever. About 30 to 50% of children less than 1 year of age will have a recent upper respiratory infection. In terms of laboratory workup, you can see an elevation in white blood cell count. You will certainly see an elevation in CRP, and sometimes you see an elevation in ESR. And blood cultures can tend to be positive in about 30 to 36% of patients. In terms of imaging workup, you do like to obtain an X-ray of the involved joints or bones, but oftentimes it does not show anything. Oftentimes you do not see the changes associated with osteomyelitis until the disease has been present for 7 to 14 days. The reason being it takes some time for the bacteria to catalyze a catalytic destruction of the bones, and that's not always obvious, but oftentimes you will see a positive MRI. We used to use bone scan, that's usually of historical value, and then we will obtain a CT scan if there's concern for chronic osteomyelitis, because that will define the anatomy from my standpoint as a surgeon about what I need to do to help take care of the infection. In terms of temporal classification, anyone presenting with less than 2 weeks of symptoms will consider it acute, less than 3 months subacute, and greater than 3 months you consider chronic. So throughout this presentation, you've noticed some X-rays that show a lot of chronic osteomyelitis. These are all children I took care of when I worked in Kenya. So in terms of treatment of acute hematogenous osteomyelitis, usually it's medically, particularly if it's caught early and there's not been development of any sort of soft tissue collection or abscess. But I have to know as a surgeon, when do I intervene? And so one thing that we like to talk about as surgeons is you want to biopsy what you culture, and you want to culture with your biopsy. In my practice, I have biopsied or performed an irrigation and debridement on lymphoma and leukemia a couple of times because they can present similar, and you do want to keep that in your differential diagnosis. So in terms of operative medications, you do want to decompress any fluid collections greater than 2 centimeters. If there's an adjacent septic arthritis, like in the hip or in the ankle, you should wash it out. If you're not sure what the diagnosis is, oftentimes you need to get a pathologic sample. And then if pharmacologic management does not work, then you should go to the operating room. So in terms of my perspective in optimizing the care for a child with osteomyelitis, so I think the most important thing is nutrition. I found in Kenya the children who were more likely to have osteomyelitis were relatively undernourished when you looked at their prealbumin levels. And you also want to optimize immune status. From my standpoint, I always want to make sure I have a good placement of incision for 2 reasons. One, you want to make sure you can have some drainage, but 2, if I accidentally biopsy a tumor, we want to make sure we can excise that tumor tract. In terms of managing the dead space, it's important because if you do not manage dead space, then you can have fluid collect, it can become reinfected. And then in terms of rehabilitation, I talked about, it takes about 2 weeks for the bone to have some decrease in density. And that's actually a problem because if the bone has decreased density, then it's more prone to fracture. So you do want to protect the weight-bearing status of the children, but you also want to optimize joint range of motion so they don't get stiff. So in our practice, we have a saying, a broken bone is a bad problem, an infected bone is a bad problem, a broken and infected bone is a very bad problem. So what happened to our patient? So we actually took him to the operating room the day of the MRI. I made a small cortical window and I cured out the infection. We were able to obtain adequate samples. And you can see this is our initial post-op x-ray. You can see there's a drain in place. These were his cultures. So he had negative blood cultures, but his OR cultures did turn up positive for Staph aureus. It is important because he was non-toxic upon presentation. Antibiotics were held prior to culture acquisition. So our patient did have a penicillin allergy. So he was on clindamycin, 600 milligrams TID for 4 weeks. But because I made a hole in the bone and the bone was weak, we did protect him and had him touch down weight bearing in a boot. 2 months after surgery, you can see his cortical window is healing. And this is about 6 months after surgery. He's doing quite well. All right, so I'm going to turn it over to Dr. Rapsinski to talk about the medical management.
Thank you, Dr. McCoy. So as Dr. McCoy said, I'm going to talk about the medical management of osteomyelitis, and I am also going to start with a case. So this case is DB. He's an 18-month-old male presenting with limp and fever. 1 week prior to admission, his parents noticed him limping. They initially treated with ibuprofen, and that seemed to help initially. The limp, though, continued, and eventually he worsened to the point that he refused to bear weight on that leg. He had a fever to 101 degrees Fahrenheit, and that's what really brought the family to the emergency department for further evaluation. On review of systems, he really didn't have any other additional symptoms besides this. He didn't really have any medical history or past surgical history. And when we reviewed his family history, he had no immunodeficiencies, no issues with recurrent infections in the family, and no rheumatologic disease in the family. But we did find that his grandmother had a history of MRSA more than 5 years prior to this event happening. He lives in southwestern Pennsylvania, and he attends daycare. He does have a pet dog, and it wouldn't be a presentation from me if I didn't say there were no cat exposures. And so on physical examination, he was febrile in the emergency department at 39 degrees Celsius. His heart rate was 102, blood pressure was 107/54, and really non-toxic appearing on exam. His exam was grossly normal other than his musculoskeletal exam, which showed that he was unable to bear, he only bore partial weight on the left leg and would not really walk on it. It was tender to palpation, particularly in the proximal left tibia, and there was some mild edema appreciated on exam without any erythema or warmth. The left knee was held in full extension, and he was really resistant to the passive flexion of that knee, and the right lower extremity, however, was within normal limits. His white blood cell count was 9.3 with a not 35% neutrophils, so not a neutrophil predominance. His hemoglobin was 12, platelets were 146, which was a little low. His ESR was elevated at 30 and his CRP was 5.12. His Lyme titers were also negative. And the ED collected blood cultures. And I just so happen to have our patient with us here today, who, if you know anything about me and my love of gaming, this is Dry Bones from Mario Kart. And so you might be asking yourself, what do I do now that I have this evaluation that I'm concerned for osteomyelitis? And the good news is there's a guideline for that. This is one of my colleagues' favorite phrases. Recently in 2021, the Pediatric Infectious Disease Society and the IDSA, or the Infectious Disease Society of America, updated these guidelines based on new data that existed. And so let's start with diagnostic workup. As Dr. McCoy said, early blood cultures are positive in 1/3 of the cases of osteomyelitis, and the guideline committee reviewed 2 meta-analyses as well as 17 recent case series and found a pooled positivity rate of about 31.2%. Cultures are helpful, especially in cases that are not surgically managed, because they may be able to provide you a microbial etiology for what you're ending up treating. Sometimes the blood culture is the only positive culture that you get, but as Dr. McCoy showed in her first case, the blood culture was negative. CRP is also recommended for serial monitoring and serial measurements in order to watch for improvement. A CRP is not particularly sensitive or specific for osteomyelitis, but it does help us kind of monitor how the patient is doing overall. Interestingly, one thing we tend to notice actually in our cases is that CRPs particularly from osteomyelitis of small bones or direct inoculation of the bone rather than hematogenous osteo, those CRPs may actually be negative or within normal limits, and that can sometimes surprise people. But if you're thinking small bones or direct inoculation of the bone, think that the CRP could in fact be normal. And then it is not recommended to get a procalcitonin, and here at UPMC we can't, so that's fine. And so what kind of imaging should you get? Imaging is not technically necessary to diagnose osteomyelitis according to the guideline, but the x-rays are extremely helpful in order to rule out other potential causes of pain in the extremities. And so you can rule out fractures, you can rule out other issues that are going on with the extremity with an x-ray, and they're cheap and fairly easy to get at any institution. MRI is the imaging study of choice. For further imaging, though, it has a sensitivity of 81% and a specificity of about 67%. And so once you have concern for osteomyelitis, you want to get some imaging studies. And so the ED did a great job doing the initial workup. And so all of your diagnostics, non-invasive diagnostic tests have really been done. And now it's time to get him some imaging. And so Dry Bones went to the x-ray and it found that he had a normal left tibia on x-ray. But when we evaluated the MRI, which I think I have to go over here, we can see, yes. When you look at the MRI and you look at his left distal proximal tibia, you see this area of brightness in the proximal tibia of the left leg. And this is the area that's consistent with osteomyelitis. And then there's also this area on the corona or on the axial imaging that is brighter as well than it should be. And so he had findings consistent with osteomyelitis in the proximal tibia. He had a small cortical breach and minimal subperiosteal fluid. So you might be asking yourself now, what do I do for this patient? And the first question that may come up is whether or not this patient needs sort of any invasive procedures. And so the osteomyelitis guideline specifically suggests getting an invasive procedure done in order to try to get an etiology for the infection. I will say this is not particularly common practice here. We will defer usually to orthopedic surgery and interventional radiology, and if they feel that it is not worth getting a sample, we're fine with figuring out an antibiotic that'll work just based on what other data that we have at the time. And to be clear, this is also a conditional recommendation, and you really need to take into account what's the risk to the child of putting them under sedation, and any other risk that may be associated with getting them an invasive procedure. Dry Bones did not have any invasive diagnostic procedures done, which he was perfectly fine with. And so antibiotics is the next step for treating of osteomyelitis, and the timing of antibiotics is the first thing that the guidelines really touch on. If a patient is ill appearing and rapidly, or there's concern for rapid progression of their osteomyelitis, don't hold off, start antibiotics. In this case, you want to be broad with your antibiotic selection, and you want to start it quickly, just like any other patient who has sepsis. If they're clinically doing fine, like Dry Bones was, he was not in septic shock, you can wait until decisions are made about whether there's going to be a procedure done, but you should really not wait more than 48 to 72 hours to start those empiric antibiotics. And usually we have an answer well before that about whether or not an OR trip is going to happen for that patient. And so ultimately, Dry Bones had no procedures, and so antibiotics were started empirically. The reason we hold off on antibiotics is really because antibiotic pre-treatment is going to affect the culture yield. And so this study showed that about 85% of patients who had did not have pre-treatment with antibiotics or had a positive culture. And then those who had their procedure post-treatment, I should say, or after the treatment was done, it was more 54.2% of cultures were actually positive from the OR. And so you're really increasing the likelihood of your positive yield of your cultures if you can hold off on antibiotics until the procedure is done. And so what antibiotics should you use is really the next question that we get. And we from ID will often get these phone calls like, what should I start? So as Dr. McCoy alluded to, Staph aureus and Streptococcus pyogenes are really the main culprits of osteomyelitis in the pediatric population. And we favor at CHP cefazolin in most cases in order to treat these infections or to start empiric coverage for these infections. We do not have a particularly high rate of MRSA osteomyelitis specifically at our hospital. And so most times, if the patient is not ill appearing, we will wait until we get cultures before we would start any MRSA associated coverage. And so the question that the guidelines does address is whether or not to cover MRSA. If the patient themselves has a history of MRSA infection, this patient did not. He only had a remote history of a grandmother with a MRSA infection. You can consider covering MRSA from the beginning, or if the patient is septic appearing or with rapid progression, again, go broad, always get your antibiotics right first, and then ID will come along and help you sort out how to narrow from there. And lastly, for other organisms, you really have to base it on the history that you have from the patient. And so in a patient with something like sickle cell disease where you're worried about salmonella, you may want to be using something other than cefazolin, like ceftriaxone, in order to make sure you're covering salmonella well. You may need ID's help to look up what the rates of resistance for salmonella is, depending on if the patient has any international travel, but we are always happy to help with that. And then any dirty open fractures, decubitus ulcers, that kind of thing, obviously is Staphylococcus and strep are not likely to be the most common organisms in those cases because these are open wounds where you're not getting acute hematogenous osteo. And so dry bones did have a positive blood culture, and so which I don't know where we got blood from, but we did. And he's growing methicillin sensitive Staph aureus. And so the next question that arises for us is whether or not a therapeutic procedure then needs to be done, not just one for diagnostic purposes, which is what we talked about before. As Dr. McCoy alluded to, in children with sepsis and or rapid infection progression, you want to get those patients to an OR as quickly as possible because debridement is going to help get you source control for that infection and allow you to get the patient better faster. The studies have shown that patients are faster to come off of vasopressive support and other supportive measures if you get them to the OR quickly to debride the area of infection. And again, similar to what Dr. McCoy mentioned, abscesses greater than 2 centimeters are also going to be the time you want to go in and do a debridement as well. There aren't really great studies about what size we should be intervening on. So when you look at the data, but there are several small case series that say that anything less than 1 centimeter, all those patients do just fine with antimicrobial therapy alone without any intervention. And then, the consensus really is that anything greater than 2 centimeters, and this is, goes in line with what our orthopedics colleagues as well agree with. And then the next question that arises is how do we know when this patient can be discharged? What do they need to go home on? All those questions. And so the first question we look at is how these patients are responding to therapy. And so we'll do a serial clinical exam, checking on how the pain is doing that they started with. How is their function? Are they starting to walk on that leg when they weren't before? Are they feeling better with the boot on? And then if they had fevers, if those are improving as well, that would obviously be a great indication to us that their infection is getting under control. And then we'll often repeat a CRP about 48 hours after therapy has started to get an idea of how that CRP is trending. I will say I tend to wait a little, maybe an extra day if there's a surgical intervention, just because the surgical intervention itself can lead to some inflammation that the CRP may not be as nicely responsive. So I will sometimes say, well, let's hold off one more day. Why send a test that we're not 100% sure it's going to be intervenable upon anyway? And so the way I usually couch this to families is you have to do 3 things to go home. One of those things is not have fevers anymore if you had them in the first place. 2, show me about 50% improvement in your functionality, and maybe show me about 50% improvement in your CRP. And so why do we get these serial measurements? Serial CRPs have been shown to be associated with more complicated osteomyelitis. And so if you have a patient whose CRP is really improving more slowly, this might be an indication that we might need to get repeat imaging, need to get in there and potentially intervene on that bone. And I think those abscesses that are maybe in the 1 to 2 range and maybe not quite at 2, and so we're holding off and seeing if therapy works, this would be a good indication to us to tell us it's time potentially to get repeat imaging and potentially go to the OR because the abscess may actually be getting worse. And so what antibiotics are we going to use for definitive therapy? If we know the germ, ID is going to help you pick what antibiotic to go home on based on what the germ is that we have. If we don't know what the germ is and whether we would base it on what they improved on. And so if the patient's getting better on cefazolin, the oral equivalent of cefazolin is Keflex, and that's what we'll send them home on. In the more complicated cases, we usually have cultures, and so as a result, we'll be able to narrow based on that. And then the other question that comes up for us is whether the whole treatment needs to be IV versus oral. We haven't been doing IV for the entire treatment since I started residency, so about 10 years ago now, which is scary to think about. And so we do usually do an oral transition if the patient can reliably take the antibiotic. I will say that babies are never reliable, as Dr. Campfield would say, never trust a baby. And so in situations where you can't trust that the patient is going to take oral therapy, you want to transition them, you're going to end up wanting to get a PICC line and give IV therapy. And that can be still given at home, though. And so what duration of antibiotics do we use? For acute uncomplicated osteomyelitis, we have actually kind of gone a little bit closer to the 3 to 4 week mark rather than explicitly 4 weeks. I would say the case that Dr. McCoy showed was definitely more of the complicated because of the abscess, the intramedullary abscess and stuff like that. And so 4 weeks certainly is appropriate. For subacute osteomyelitis, so more in that 4 to 6 weeks, 2 to 4 to 6 weeks since they started having symptoms, we would do 4 to 6 weeks of therapy. And then for chronic osteomyelitis, it's usually a minimum of 3 months of therapy. And then we will sometimes reevaluate how the patient's doing. We'll get repeat imaging, all those kind of things to help us decide when to stop therapy. And we follow these patients very closely as outpatients. And so if we haven't told you when the patient has an appointment or haven't given you a phone number to help the patient call to get an appointment, let us know. And so for dry bones, he received IV cefazolin for about 3 days in the hospital. He did great. He got much of improvement. His CRP went down to 2.25, so it was down about 50% from where he started. And then he was ultimately transitioned to oral cephalexin to finish a 3-week course of therapy. And then when we saw him in outpatient therapy, he did great, and he was back to driving his little race car and playing tennis in about 3 months. And I will transition back to Dr. McCoy to talk about the complications.
Okay, well, thank you so much, Dr. Rapsinski, for such a nice overview of medical management of osteomyelitis. So now we'll transition to some of the complications, and this is why we want to catch acute hematogenous osteomyelitis early. So in terms of complications, we can have sepsis, as we talked about. You can have physeal disturbance, so the growth plate can stop functioning, and that can lead to restriction of longitudinal growth and can also lead to angular deformity. And then you can have chronic osteomyelitis, which can lead to focal or segmental defects of bone, pathologic fractures. And then if you have a long-term draining sinus tract, that can have malignant transformation into squamous cell carcinoma, as well as amputation. So we're going to go over another case. So case BK is a 6-year-old girl with a history of sickle cell who presents from an outside hospital in sickle cell crisis with a draining right forearm for 2 years. The family recently immigrated from a refugee camp in Burundi, and the wound started about 2 years ago after a blood transfusion. So the patient has sickle cell disease. She takes folic acid and hydroxyurea and lives at home with her mom and 8 siblings. So on presentation, the patient had a temperature of 38.2. She was tachycardic and had a blood pressure of 95/57. In terms of focal examination of her arm, she had a draining sinus tract from the right proximal ulna with purulent drainage, and she was neurovascularly intact distally. In terms of her laboratory workup, she had a white count of 11.6. She had a hemoglobin of 3.1 and a platelet count of 97. So these are the patient's presenting x-rays, and I'd like to go over them with you. So you can see this is the ulna, and you can see there is a hypersclerotic reaction that we call an involucrum surround. Oh, this one, thank you. Okay. You can see there's a hypertrophic involucrum musculosis, and you can see that's surrounding a sequestrum, and you actually can see some osteomyelitis in the radius. So this is the MRI that was initially obtained, and you can see some local tissue edema as well as the sequestrum. Same thing on the axial cuts, and you can see the draining sinus tract right there. So as I mentioned before, it's very helpful to use a CT scan to better define osteomyelitis. So this is an axial CT scan, and this is the humerus coming down. This is the ulna, this is the radius, and you can see this is the sequestrum. You can see that's a draining sinus tract from where the pus is coming out. Okay. Same thing on the axilla. So you saw the sequestrum. Okay. So the patient eventually received blood transfusions and was stable for the operating room. So we took her to the operating room where I excised the sinus tract, but then I had to reestablish the intramedullary canal. So one thing that people don't think about in the surgical management of a chronic osteomyelitis is that you need to get the antibiotics to the bone. So if the bone is walled off, you have to make a channel. So it's very important when you're taking care of chronic osteomyelitis to reestablish the intramedullary canal. And so I actually did this with a flexible nail. This is what I use to fix forearm fractures in little children, but it works the same it's kind of like a router. And so we did that for both the ulna, and you can see we did it for the radius. And so at that time, we were able to obtain cultures, and unfortunately, we had multi-drug resistant salmonella, but we were pretty happy. The wound was healing, and the patient was doing well, so we discharged her. A few weeks later, the patient comes back. She has increased purulence from her right arm, but she also describes right leg pain. And so we took x-rays, and you can see that this is chronic osteomyelitis with the sequestrum. And so the one thing I want you guys to remember is that osteomyelitis comes from bacteremia. Bacteremia can see it in multiple places, including the bones, including the heart. So it's really important to think about that. So we got a CT scan of the femur. And this is the axial cut. And you have canal here. And there's no canal. And then you can see the sequestrum. And then you can see the sequestrum exiting. This is the coronal cut of the femur. Oh, sorry, it's a sagittal. And you can see this is the sequestrum, right? A huge piece of bone right there. And now we're on to the coronal cut. Large sequestrum right here. Fortunately, the patient did not have a draining sinus tract. So we took the patient to the operating room. We did a lateral approach to the femur. I pulled out that big sequestrum, and then we curettaged it, and we reestablished the canal. And so that is where Binti was a year ago. Since then, Binti has been on chronic antibiotics. She did have a little bit of a difficult time obtaining her antibiotics, so she had a little bit of reactivation of her disease when I saw her in December, but overall, she's doing much better. But this is a case where you need long-term suppression to prevent reoccurrence of infection. So we're going to go over another case. JJ is a 12-month-old boy who came to the ED with 2 weeks of upper respiratory symptoms and increased work of breathing. The patient had a cardiac arrest and was placed on ECMO, and then he developed a right MCA stroke and left leg swelling. Before this, the patient was healthy and lived with his parents and dog. So this is the initial x-ray that our orthopedic service obtained of JJ in 2023. And you can see there are some changes here of his femur, some lytic changes that look like he's developing osteomyelitis. So at this point in time, the patient had to have osteomyelitis for at least 2 weeks. The patient was washed out multiple times. Unfortunately, the destruction continued to persist. So here I would describe this as a pathologic metaphyseal fracture with a Salter-Harris 2 distal fracture component. And at this point in time, we had a hard conversation. I did speak with the family, and we did attempt limb salvage. I did try to fix this fracture with a small intramedullary nail, but after 3 months, it failed. So we ended up doing an amputation about a year later. The patient recently moved to Atlanta. I'm actually in touch with his physical therapist, and he's actually getting around pretty well with the transfemoral prosthetic. But I wanted to show this case because this can happen with osteomyelitis. So from today's talk, I hope you have the following take-home points. Acute hematologous osteomyelitis should be considered in the differential diagnosis of a patient presenting with atraumatic limb swelling and fever. Medical management is the mainstay of treatment in the early stages of osteomyelitis before the development of fluid collection and abscess. Blood culture should be drawn before the initiation of antibiotics and will be positive in 30% of the cases. And in terms of my practice as a surgeon, indications include a subperiosteal abscess or fluid collection greater than 2 centimeters, adjacent septic arthritis, uncertain diagnosis, and failure pharmacologic management. And finally, I hope you took away from our last cases, complications of acute hematologic osteomyelitis can be life-threatening and limb-threatening and last for a lifetime. I'd like to thank you for your attention, and I'd like to open up the forum for questions.